Everybody, this is the reason why you're here today. You have got to look at bringing in clinical services. There are so many things out there, outcomes and CSPN and all these things that are trying to get community pharmacies more involved in clinical, but every one of those solutions, every one of them has a ceiling. They want you to operate at your highest, level of your degree. All of our PharmDs that are, doctors of pharmacy, but because you are doing these services under your pharmacy's NPI, you have a ceiling. You're never going to break through that ceiling. You're always going to get reimbursed tier one reimbursement. The Community Care Initiative, IPPN, the Independent Pharmacy Provider Network, does two main things for you. And I'm going to turn the time over to Ray to tell you about those. But the two main things are it breaks that ceiling because of collaborative practice agreements with your local physicians in your area, and then it's the credentialing on the medical side. So you're completely changing from the pharmacy over to medical with low-hanging fruit, the things that you guys are already doing, like vaccinations, point-of-care testing. And literally, you'll see quadruple or even more on what those reimbursements can be when it's done right. So not putting down those other programs like outcomes and everyone's trying to bring to you. This just brings it to a much, much higher level of what you can and can't do because of the collaboration with physicians. So, Ray, please take it away.
Thank you, Brack. I appreciate it. You can hear me, right?
Yep.
Yeah, yeah. So really, my background goes back to 2003. So it's a little over 20 years in healthcare IT, and I've worked with healthcare providers, both large and small, state, city, national initiatives, community initiatives. And, as Breck and I were talking about some of the opportunities that are out there with respect to independent pharmacies, I realized that there was an opportunity here for us to be able to help organize these organizations in a way that they can create a sustainable, collaborative agreement with local providers. So one of the things that we needed to do was to be able to create a process that aligned with those goals. And so what we did some research, we talked to people, and we realized the biggest problem that independent pharmacies have is number one, alignment with some of these local providers that are going to be able to direct patients to them instead of just wherever the patient wants to go, like a CVS or a Walgreens. There's absolutely nothing wrong with that. That collaboration is part of equity and engagement that CMS is trying to promote. So in putting this together, we realized that we needed a state by state agreement. We looked at every state, so we're able to essentially offer the solution in every state currently. We've got some experts on how these collaborative practice agreements come together and how they're put together. We just brought on a professor at the University of Nebraska at Lincoln that teaches collaborative practice agreements. So those experts are available to anybody that we work with. And what does that allow them to do? It allows them to get access to new revenue, as Breck said, break that barrier, go beyond level one billing, go beyond that opportunity that is only afforded to you that CMS is saying, hey, a pharmacist can only do this. Change the dynamics of the conversation, right? If you want to keep going after, sometimes you need to change the dynamics, as I said. If you can't bill higher amounts as a pharmacist, then do a collaborative practice agreement with the provider that allows you to do that. IPPN has also set up a process for patient engagement. They would set up a process for recruitment of local providers. We have backstop providers that are national providers that can handle some of the telehealth calls. We have an application. That application actually has handled now over 300,000 encounters since we launched it for other providers that utilize it directly or indirectly through collaborations. Currently, we're in 12 states that we've gotten what we call letters of intent, and we're working towards a rollout within the next anywhere between, well, we're live now to 90 days from now, we'll be live in over 12 states. So we're getting a lot of interest. And again, we try to make it turnkey. The ability for a pharmacy to be able to do an e-visit consult that allows for an immunization or a flu vaccine to be dispensed or to be offered, that allows them to bill 3 or 4 times the amount of what a G0008 would do for a billable encounter with the pharmacy is significant. It could be the difference sometimes between staying in business and going out of business. So again, change the dynamics, align yourself with an organization like IPPN that has vetted out everything that you need to do in every state. We have compliance, we have the application, we have the ability to do that. And what Breck has up there is if you scan any one of these codes here, these QR codes, it's essentially a process. You can actually then do a health risk assessment. You can engage an e-visit consult. You can get access to new revenue by documenting social determinants of health with your patients. So there's other opportunities beyond just what's available for pharmacies. If you want to just jump to the next slide, Breck, I want to with the revenue for every 1,000 patients that are seen. We expect that a pharmacy may end up seeing roughly about 100 patients per month. 25 a week, anywhere between 4 to 5 patients per day through this model. They'll end up making approximately a gross profit of almost $42,000, a little over $42,000. You can allocate money to staffing. And we demonstrate that here where you're going to be taking approximately 22% for staffing. But essentially, you're making over 40% return, and the setup fees are minimal. The setup fees are, less than if you annualize it, it's less than a few. It's approximately $7,500, and it's paid over 3 months. So it's about $2,500 a month for the first 3 months. But that gets your new clinic set up. That gets your credentialing, which is a big deal. Many pharmacies have tried to set up these collaborative practice agreements, and some of the places where they fail is corporate structure. The next point where they fail is credentialing, contracting and credentialing. They're not getting the contracts. The third place is keeping those providers, those local providers engaged so that they continue to refer and work with these pharmacies. So again, Breck put up a link where it's a simple letter of interest. Once we know what the state number of pharmacies, then we can come back and actually put together a proposal that'll lead to a full-blown collaborative practice agreement that's going to be operational within 90 days.
Thank you, Ray. And I'll mention too that I spammed the chat a couple of times there with that link for the LOI, the letter of intent. You get 10% off for doing the LOI today. If you are a ServeRx customer, you also get an additional 10% off. That's 20% off, folks. So absolutely believe in this program. I'm so excited to bring it to our community pharmacies. It is literally the first 2 steps of what is needed in order for a lot of you have heard me talk about setting up your own turnkey wellness clinic, having your own wellness clinic right inside of your pharmacy. You can't do that without the network. You've got to have the IPPN, the Independent Pharmacy Provider Network, for the 2 reasons that I talked about. Not only the better reimbursements, but you've got to have the collaborative practice agreement, and you've got to have credentialing. And Ray's team goes out and recruits those doctors for you. Hopefully, you have a good relationship with 1 or 2 physicians in your community, but they'll literally go out and recruit those physicians for you. There is, Ray, wouldn't you say there's a first mover advantage here? Definitely on that
Yeah,
side.
absolutely. I mean, we're because also you have a limited number of providers that are in those areas. And Auditoro asked a question: who pays the provider fee? The pharmacist is the one setting up this entity. It's controlled by the pharmacy. All payments, even though there's a billing that happens as part of that clinic, we set up a new NPI number. That is controlled by the pharmacy. The collaborating providers are essentially providing their license in order to be able to get prescriptions, in order to bill. And in some states, you need to have a provider in order to have a collaborative practice agreement. So they only get a piece of the ongoing fee, but the setup, everything is done directly with the pharmacy. We want to put the pharmacy in control here.
Yep. So the IPPN is the virtual clinic. Then the brick and mortar clinic is the BRIM program that you've heard me talk about. And I'm not going to take time to go into details because you've got to start with IPPN. But I do want to share this one little box up here. This is an actual client of ServRx who did almost 10,000 flu shots last flu season. His reimbursement, now he's got multiple stores, so that wasn't just one location, but his reimbursement for that last year was 167,400. After credentialing and getting set up with IPPN, his reimbursement for doing the same work will be almost $1 million. Okay, this is real, folks.